All the tests that I'm going to be performing in this video are from the lower extremity reference section. So for the flexion, adduction, and internal rotation test, we're going to be referring to reference 3. This is going to be testing for femoral acetabular impingement, also known as FAI, or a labral tear. And you're just going to have the patient begin in a supine position. Clinician is going to bring the leg up, flex the hip to a 90 degree, and here, and then adduct, and then compress, and internally rotate, and then reverse that position. So a positive for this test would be a reproduction of the patient's symptoms. And the reason why this test works, or it's a good test, is because, so with FAI, we have the acetabulum, and it can be slightly extended or a little bit more than it should, or more than normal. And if it is, or you can also have actually the femoral head have some more bone on it, and it should be nice and smooth, and if it isn't, then it can, this position of the flexion and adduction can pinch that area and the structures in that area, causing pain. And with the labral tear, when you do the rotation, it is going to be catching on the spot that is torn of the labrum. Now, so if you're specifically looking for FAI, you technically don't have to do that full test with the rotation. You'll be finding it with the flexion and adduction. With the labral tear, you're going to have to go through all 3 steps: the flexion, adduction, internal rotation. The specificity for this test is 10. Specificity is 10 to 100%, and sensitivity is 75 to 100%. Now this seems very vague and very obscure. However, this was one of the best tests that I could find for the FAI and labral tear, and that's where we just need to get more research and to all of these tests. So for the flexion internal rotation test, we're going to be testing for FAI, which is the femoral acetabular impingement, and a labral tear. And we're going to be referring to reference 3. The patient is going to be in a supine position. The clinician is just going to flex the hip up into a 90 degrees, and then internally rotate with the overpressure. So I'm compressing down here, and then just reversing that position. And a positive for this would be reproduction of the patient's symptoms or pain. The reason why this works is the same thing as the previous test of FAI and labral tear. And sensitivity for this test is 100%, and specificity is 0%. So this would be one that you would definitely want to try the other test with and have the composite testing. So for the Trendelenburg test, you're going to have the patient standing, and then go ahead and ask them to stand on one leg. Good. And go ahead and relax. And you're going to be looking for the contralateral hip to drop. That would be a positive. So she was a negative since her hips were even. Now go ahead and do a positive for me. So she would be pathological on this side, and then this side is the opposite side, and she has the contralateral drop. This specific test tested for glute medius tear, and the sensitivity was 73%, and specificity was 77%, and with a quadus of 11. So it was a pretty good test. However, it did find a lot of since it was testing specifically for a tear, it did find a lot of just glute medius weakness, So it would be, if it wasn't testing for a tear, it would be a better test specifically for glute medius weakness. This works because if the glute medius helps us abduct and is one of our abductors, so being in this position, you're having to maintain abduction, and they're unable to when they drop the contralateral hip. So it puts their leg in an adducted position. And we're going to be referring to reference 1. So for the Apley's test, we're going to be testing for a meniscus tear. And we're going to be referring to reference 8. And the patient is going to lie prone, and the clinician is going to bring the patient's leg up to a knee to a 90-degree angle, and we're just going to press here on the distal femur, and then distract, and then rotate, and then compress, and then rotate. A positive sign with this would be the same as the Thessaly's, would be clicking, catching, popping, or locking. And this is just due to this meniscus kind of floating around in that area if it is torn. And the sensitivity is 16% and specificity is 100%. So this would be one that you'd really want a composite test for with the Thessaly test. So for the Thessaly test, we're going to be testing for a meniscus tear. We're going to be referring to reference 4, and you're just going to have the patient stand and then slightly bend your knee just a little bit, and then you can hold on to my hands here, slightly bend, there you go, and then you're just going to have them rotate back and forth. Good, and you're going to do that like 3 times or so. Go ahead and relax. And a positive sign would be clicking, catching, popping, or locking, or pain in the knee. And this is due to having, if you do have a meniscus tear, there are going to be pieces that are kind of floating around, and it's just going to catch or lock or pop when performing this motion because it is being compressed. The sensitivity for this test is 90% and specificity is 97%. And that is it. So for the anterior drawer test, we're going to be testing for anterior cruciate ligament tear, which is the ACL. And you're going to have the patient lie in a hook lying position. You can sit on their foot, and now you're going to wrap your hands around the tibia, and then you're just going to pull forward. And a positive sign for this test would be excessive movement anteriorly of the tibia. And this is due to the anterior cruciate ligament prevents anterior translation of the tibia. So if it is torn, it is not going to stop this motion. So excessive movement will occur. And the sensitivity is 91% and specificity is 89%. And we're going to be referring to reference 2 again. So for the posterior sag sign test, we're going to be testing for the posterior cruciate ligament. And with this, you're going to have the patient lie supine, and the clinician is just going to lift their leg up, and you're going to be looking for dropping of the tibia, so the tibia is going to be going posteriorly, and obviously she does not have it. So this is just going to be testing for the PCL tear, and this happens because the PCL prevents posterior translation of the tibia, and so if you lift it up, it's not going to be able to stop that motion. Sensitivity for this test is 90% and specificity is 99%, and we're going to be referring reference 9. So for the posterior drawer test, we're going to be testing for a PCL tear. We're going to be referring to reference 9, and with this you're going to have the patient lie in a hook lying position. You can sit on their foot, and you're just going to push the tibia posteriorly. So just pushing back. Positive sign would be the same thing as the sag sign, and just excessive movement of the tibia in a posterior direction. And the sensitivity for this is 90%, and specificity is 99%. And so the same thing as before this works, because the PCL prevents posterior translation of the tibia, and so if it's torn, it's going to allow that movement to occur. So for the anterior drawer test for the ankle, this is going to be testing for an anterior talofibular ligament tear, or anterior talus displacement, it can also be called. And the patient is going to lie supine or in a long sitting position with the knee bent, and I'm going to hold down the forefoot and place my hand on the distal tibia and then just push posteriorly. And there's also another way, and just come forward just a little bit for me here. Okay, and I'm going to hold now here, moving the calcaneus anteriorly. Both of these, the positive will be gaping in the, kind of in this region, which is the ATFL, and you're going to want to compare it to the opposite side. The sensitivity for this test is 100%, specificity is 100%, and the quadus is 7. Now, the reason why this is a good test or why this test works for the ATFL is because there's a lot of ligaments within this area, and they stabilize the ankle. So if you pull in this position, if it is torn, it's going to provide that gaping, and the movement will occur. And we're going to be referring for this section reference 6 and 7. So for the medial talar tilt test, we're going to be referring to reference 5, and you're going to have the patient lie supine or they can sit, and you're going to hold the tibia here and then just move the calcaneus medially. And the positive sign for this is excessive movement in this area, and this is for testing the calcaneofibular ligament. And this works because the calcaneofibular ligament attaches to the fibula and the calcaneus, and this motion, if it is stretched, is going to allow for the excessive motion if it's torn or overstretched. And the sensitivity for this is 67%, and specificity is 75%. So not the best, but this is one of the best tests, as I said before, one of the best tests that I could find for